whenever a large part of the body is involved in the process of surgery, or the surgery is in an area like the chest, the abdomen, brain, the oral cavity, the mouth, the deeper parts of the body in the neck, like the larynx, the trachea, neurosurgery, cardiac surgery, renal surgery, surgery involving the vital organs like the liver and the spleen. All this involve a larger area and prolonged surgery. These are the patients in whom we would like to have general anesthesia. There are surgeries of the ear or of any peripheral parts also, which would take a much longer duration, and sometimes patients are averse to the idea of local or regional anesthesia. Local, of course, is not possible because it involves a large area, but patients are averse to the feeling of regional anesthesia. In these patients, we would like to give general anesthesia. Anesthesia has four elements: analgesia, amnesia, paralysis, and unconscious. The general anesthesia should provide for all this. And for providing for all this, what we do is, every patient who is on our table for anesthesia, a peripheral line is taken from which we start our intravenous fluids. The patient, after proper pre-oxygenation, is injected with a dose of an anesthetic analgesic agent. This, within a short span of a few minutes, takes the patient into a stage of depression, and the patient almost loses consciousness. For this patient who has lost his consciousness, we have different methods. One of them is, this patient who has lost his consciousness, we ventilate the patient with a mask, give the patient a neuromuscular agent. This neuromuscular agent is a paralyzing agent which is going to paralyze his muscles of respiration. And an endotracheal tube or a laryngeal mask airway is introduced into the windpipe or the trachea of the patient. And the anesthesiologist takes over the control of ventilation of the patient. The patient is now being ventilated by the anesthesiologist, either manually or is put onto a machine, one of the ventilator types, which keeps ventilating him. The patient is given regular doses of anesthetic analgesic agent to depress his consciousness, is given regular doses of the neuromuscular agent to keep his muscles paralyzed, and the surgery goes through. At the end of the surgery, the patient is reversed from the neuromuscular agent, from the paralysis, and the paralysis is abolished by giving the exactly opposite group of drugs known as the reversal drugs, whereby the paralysis disappears and the patient's muscular activity returns. At the same time, the anesthetic analgesic agent which is being given to the patient, either in terms of injection, which goes through the saline drip, or through inhalational gases which are delivered via the endotracheal tube, they are also decreased and the person comes back to consciousness. When we have a conscious patient on the table at the end of the surgery who is able to breathe on his own, the patient's endotracheal tube is removed, and this is known as extubation. So any general anesthesia of this manner has three stages: an induction stage, a maintenance stage, and an extubation stage. This induction and recovery are both like the takeoff and landing of a flight. They can be turbulent at times, but most of the times we hope it is smooth. The maintenance part is most of the time a smooth drive, unless if turbulence occurs, the surgeon and anesthetist are both helping each other during these turbulent times. Either it could be a surgical cause or it could be an anesthesia cause, but they stand by each other and wade through the situation. During this entire process, from the induction to the extubation, the patient is being continuously monitored. His pulse, BP, heart rate, temperature, the percentage of oxygen going within his system, and the carbon dioxide which is created by the body has to be thrown out. So the level of carbon dioxide in the patient system, all these are being continuously monitored on our system. This patient who has come out of anesthesia is now shifted to the recovery room, and post-operatively, this person is monitored for all the parameters till he is fit to be shifted to the ward. Even after he is shifted to the ward, depending on the surgery, depending on the duration of anesthesia, depending on the response of the patient may be kept in the ward for the number of days as required, as per the surgical requirement and as per the anesthesia requirement. Most of the time, in 24 hours, the person is totally free of most of these side effects of the anesthesia, like nausea, vomiting, shivering, or he may have soreness in the throat because of the endotracheal intubation. Now, why I say 24 hours is because the drugs that we have injected in the body have to be metabolized by the liver and have to be excreted by the kidneys. So, if this metabolism is going to take long, or if this excretion is going to take long, then it is an individual perception. Some patients may be awake in 2 hours, some patients may sleep for 6 hours. The inhalational agents that we give, the gases which we give, have to be thrown off by the lungs as exhalation. When the patient exhales his breath, these inhalational gases have to come out. And this may also take time. So the patients who recover, some, as I told you, it is an individual difference of how fast the patient comes out of this. This is one form of general anesthesia, and it is known as balanced anesthesia. There are other methods too, and it is left to the individual anesthetist choice, the surgeon's choice, and the patient's comfort level as to what sort we can do. Because in some patients, we need not depress their respiration, we need not intubate them. For example, if it is going to be an ear surgery, in which case we don't have to depress his respiration or intubate him, we can give him something called total intravenous anesthesia, which is TIVA. In this, the anesthetic analgesic agent is given to the patient in a drip form, and the medicine is added to the saline or glucose or dextrose or whatever is being given to the patient. This agent keeps the patient sleeping, a little sedated and drowsy throughout the procedure, and the surgeon has already given a block near the ear. So these anesthesia methods which I am using are supplementary and complementary. I can use local anesthesia with sleeping agents, regional anesthesia with sleeping agents. I can use blocks with anesthetic agents which will make the patient sleep for a longer time. So all this is complementary of one another, and the choice of anesthesia to be given to the patient is most often discussed by the surgeon and the anesthetist, and liking of the patient, we decide what's to be given. It may be a very small procedure, but if the patient is very apprehensive and is not willing for local or regional, then of course we go ahead and give general anesthesia. Each method of anesthesia will have its own inherent plus and minus points, and we have to make a judgment of what is best for the patient. As far as local anesthesia and regional anesthesia is concerned, the patient is not unconscious. The patient has had a block, and we are giving medicines to keep him a little drowsy, keep him a little sleepy, keep him relaxed. When general anesthesia comes into the picture, the central nervous system is depressed to an extent that the patient is deeply sedated, as I told you, in total intravenous anesthesia, where his respiration is not hampered, he is breathing on his own. And when I spoke of balanced anesthesia, where I'm putting a tube into the throat, the trachea of the patient, oral laryngeal mask airway, I'm completely taking charge of his respiration, which means he's totally in a comatose condition and he's perfectly unconscious. Normally, in such balanced anesthesia technique where the patient is unconscious, it's the awakening thing is not very common. It could be one of a rare situation which has been recorded in some statistics, but normally not. When the person feels that he is awake or when he starts feeling it, at the end of the anesthesia procedure, when we are reversing him, when we have decreased or completely stopped these anesthetic agents, when the neuromuscular agents have been reversed by the reversal medicine and the patient is coming out of anesthesia, he feels he was awake or he feels he was dreaming or he's coming back to consciousness, and that effect of pain and a very weird atmosphere in the operation theater makes him feel so. But during the entire process of anesthesia, I wouldn't think that there could be any question of awakening. Yes, there are certain surgeries in which we have an awakening situation to judge the patient's response for certain things. At that time, we definitely have to wake up the patient in the middle of the anesthesia to see whether certain positive features are there, and we take back the patient again to the deep level of anesthesia and put him to sleep again and deepen the level of his unconsciousness. Pain of the surgery would rarely be felt. I would say it would never be felt, because whether in the case of local or regional anesthesia, as the effect is wearing off towards the end of the surgery, say after a period of about say 45 minutes, 1 hour, 15 minutes, patient may start feeling the pain. And in such cases, if the surgery is not over or completed and patient is feeling pain, we supplement the local anesthesia or the regional anesthesia with general anesthesia. That is, these two techniques, the local anesthesia techniques and the regional anesthetic techniques, are time bound. The effect of the local anesthetic can get over and patient may feel pain. The moment the patient feels pain and we are aware that the surgery is going to take longer, we supplement the patient with general anesthesia. That's the reason when a patient comes for surgery, whatever may be the method of anesthesia we have chosen, local or regional, we are always prepared for a situation of general anesthesia. See, some anesthetic agents have the property of hallucinations or delusions. Now, when we are using such agents, we try to combine it with something whereby the delusions or hallucinations can be decreased. But in spite of that, it is not during the surgery per se, but when the patient is coming out of anesthesia, the patients do have some delusions and hallucinations, and they do complain of it. But this is not with all agents. There are a very few of these agents which have the basic pharmacological properties of delusions or hallucinations. The anesthesiologist per se is the perioperative physician of the patient who's going for surgery. Means he is going to monitor everything preoperative, intraoperative, postoperative of the patient till the patient goes back. Now, what happens is when a patient goes for a surgery to a particular doctor, the surgeon would advise a battery of investigations depending on the requirements. Some of these investigations would be for surgery per se, but by and large, most of the investigations are for the purpose of anesthesia. Now, the list of investigations or the requirement of investigation would vary from individual to individual, from circumstance to circumstance. For example, I can answer this question of you by giving examples. A young person A young individual of say 20 years for a simple surgery of hernia goes to the doctor, asks for investigations of maybe a hemoglobin and blood count for this person, because all that we need to know is that his blood level is adequate, his blood count, his cell count, to see that he has no infection. But if this young man is a smoker who is smoking 40 cigarettes a day, then in addition to that, we also have to take care of his lung status. If this young man is an alcoholic, then we also have to know the status of the liver. So we need to advise investigations depending on the patient. Instead of a young 25-year-old man, if I have a person in the 30 to 40 age group who's come for the same surgery, this man is healthy, he has no issues, I would advise him basic investigations like the same blood count and things. But if this man is a diabetic, if this man has had a past history of jaundice, if this man is an alcoholic, or this man has an hypertension and is on medication for hypertension, my list of investigations would change. If a person he comes with a kidney problem, the list of investigations would change for the person with a kidney problem. An old person above his 50s coming to us for anesthesia, we have to be very careful of his heart status, his cardiac status. A person who comes to me with an history of an heart attack, a person who comes to me with an history of having done an angioplasty, a person who comes to me with a bypass done, the investigation changes as per the requirements of the patient. Now, one would ask why the surgery is the same. Why would the investigations list change even if the surgery is the same? Because per se, surgery is just for one part of the organ. But when we are giving anesthesia, the drug travels all over the body. This drug, which is a central nervous system depressant, is going to depress my lungs, is going to depress my heart, and being excreted by my kidneys and my lungs. All these vital organs have to be in an optimum state to bear the stress of this surgery and anesthesia. If my liver status is not good, if I have a history of jaundice, if I have had a liver abscess, if I have cirrhosis, the optimum ability of my liver to metabolize these drugs will be low. And when these drugs are given, the liver will take a longer time to metabolize. So when I take the patient for surgery, I should know the optimum level of action of all these vital organs. Hence, there are liver function tests, there are kidney function tests like BUN, creatinine, there are lung function tests like pulmonary function tests, which are required in certain individuals, not everybody. Each individual who presents for surgery and anesthesia is a challenge to the anesthetist. And every challenge has to be met in a different style, in a different mode, with having committed so that the patient will be totally comfortable. In today's circumstances, we have gone far ahead in our surgery, because if you look at it, we have laparoscopic surgeries, we have robotic surgeries, we have colonoscopies, we have OGDs, and we are heading to an era where we are in transplant surgery. Each of these patients, surgery has developed with the support of anesthesia, and anesthesia progresses because of the challenges of surgery. Surgery and anesthesia are two complementary branches. Without one, the other can't progress. And for us to progress, we have to walk together. So the patients understand surgery because they look at the surgeons day in and day out. But when you look at the anesthesia part of it, people are not much aware of it, because for them yet, why do you have to do so many things? I have to do so many things because I should know the optimal status of the vitals of the person before I enter into an arena where I'm going to give external drugs, where I'm going to introduce techniques, and I want to see that the patient can bear and handle all these things and come out safely. Post-operatively too, the patient has to be monitored because, for example, in a diabetic patient, the sugar level has to be monitored well, brought to an optimum level before we take up the patient for surgery. Because intraoperatively, the blood glucose may rise or fall to drastic levels, and they have to be well monitored. That's the reason why sometimes you feel that either the surgeon or the anesthesiologist will ask for more time and postpone a routine surgery till the patient has reached his optimum level in all functions of the vital organs. In an emergency, of course, there's no go, and we take the risk that is offered, and we go ahead and do the case with hoping the best for the patient, taking all precautions that are necessary to handle the situation.